Hello, my name is Brooke. I'm a pediatric oncology nurse practitioner, and today I'd like to talk to you about a complication that we sometimes see in our pediatric oncology population. It is called SOS, or Sinusoidal Obstruction Syndrome. It used to be called VOD, or veno-occlusive disease of the liver. Now, SOS most commonly occurs after hematopoietic stem cell transplantation and bone marrow transplantation in children, sometimes up to 20%. But it can also occur after routine chemotherapy administration. SOS has been linked to certain chemotherapy drugs more than others based on their level of hepatotoxicity. It has also been linked to certain monoclonal antibodies such as inotuzumab and certain oral chemotherapy drugs such as thioguanine. When talking about transplantation, allogeneic transplants are at a higher risk than autologous, and infants and children have a higher risk than adults. Pre-existing liver disease also increases our risk. Let's talk about pathophysiology. The first thing that happens is there's damage that's done to the liver endothelial cells. This damage causes fibrinogen, clotting factors, and cell clumping, which leads to congestion of the sinusoids. The sinusoids are the small vessels that are inside the liver. This congestion and clumping causes impediment of blood flow and cell lysis. Platelets are then going to be decreased as they clump on the vessel walls, and red blood cells are going to be lysed as they try to travel through the liver vessels. The sinusoids become dilated and they leak protein-rich fluid into the extravascular spaces through the liver. This causes ascites in the abdomen. Eventually, blood flow will be reversed through the portal vein in the liver and can also affect renal blood flow. Let's talk about signs and symptoms. You can have increased bilirubin, ascites, altered liver function tests with your patient, altered coagulation studies, hepatomegaly, right upper quadrant pain, and that's because the capsule surrounding the liver will become swollen, and that's very painful. Weight gain, which is often an early symptom or an early sign, jaundice, decreased platelets, and platelet refractoriness. And when I talk about platelet refractoriness, what I mean is that when you give your patient a platelet transfusion, you don't have as good of a rise or an increase in their platelet count after you give them that transfusion. Nurses play a fundamental role in the early recognition and identification of these signs and symptoms because they spend so much time at the patient's side. The diagnosis is made clinically, but we use two sets of diagnostic criterion which help us to delineate whether or not the SOS is mild versus moderate versus severe. These scales or these grading criteria look at things like weight, hepatomegaly, and labs to make the determination. They're called the Baltimore and the Seattle criteria. The treatment for SOS is really based on prevention, first and foremost. Clinicians must assess the risks that their patient has prior to going into a hematopoietic stem cell transplant or bone marrow transplant. Oftentimes, these are risks that we can't modify, but it might make a difference in the prophylactic treatment the clinician decides to use. Treatment is really based on supportive care. We need to avoid hepatotoxic agents, so we need to look at all of the medications that our patient is on and try to pull away the medications or substitute different medications for ones that they're receiving that will be more hepatotoxic. Patients are usually treated with prophylactic medications, and there's 3 prophylactic medications that we tend to use. The first is ursodeoxycholic, which is a cytoprotectant. It's an oral medication that's given from the time that the patient starts the conditioning regimen for their hematopoietic stem cell transplant or bone marrow transplant and is taken daily all the way through until the time of discharge. We oftentimes will use a heparin drip prophylactically. And the last medication that I've seen used prophylactically, which is also used in treatment, is defibrotide. Supportive care is the key. Keeping track of your patient's fluid balance, managing their pain, and sometimes we've even done a paracentesis or drained that extra fluid from the ascites off of the patient's abdomen. The number one treatment currently for severe SOS is defibrotide. Some institutions will use this prophylactically, but it is the #1 drug for treatment. The way that defibrotide works is actually not completely understood, but we do know that it does prevent and break down clots that are forming in the liver. It's given IV for 21 days every 6 hours. Nursing plays a big role in not only the recognition, like I already mentioned, but in the treatment of SOS, because a lot of the treatment is supportive. It's important that nurses keep an accurate intake and output for their patients, that they record their patient's abdominal girth and report any changes, that they monitor their patient's weight, that they watch for the lab results to come back and notify the provider for changes, and that they assess their patient's abdomen. Even if they're not trained in abdominal palpation, they can still report pain to the medical team. They need to assess for pain, ascites, and jaundice, and they need to be in control of their patient's pain, making sure that they are as comfortable as possible. I hope that you learned a little bit today about SOS. Until next time.